All right, good morning, everyone. We'll go ahead and get started here. I have Hannah here. She is the OR manager of the CV at Memorial in Springfield, Illinois. So just giving a little introduction there to Hannah. What was it that got you into nursing in the first place, Hannah?
Yeah, great question, Brandon. I always kind of knew I wanted to go into healthcare, and originally I thought I wanted to become a CRNA, do the nurse anesthetist route, which I kind of that was my goal all through nursing school. And then I had accepted a job on a cardiac step down unit, was there for about a year, and kind of realized I was like, I don't really think I love the clinical side of nursing, taking care of patients at the bedside necessarily. And so I transitioned to the OR, and that's kind of what led me into the OR leadership and getting into management. I kind of fell in love with the perioperative side of nursing and the leadership side.
Yeah, it sounds like we had kind of similar paths there. Like I was kind of on that same path of wanting to do CRNA, and then I did cardiac step down and said, I don't know if I really want to do that. And then ended up in the OR for a little bit before transitioning back into more like administrative roles. So tell me about like your full journey of nursing. Like what was it? How did you get where you're at? Where have you enjoyed the most in your rotations? Just to give us some background.
Yeah, so I worked on the cardiac step down unit for about a year, and then I transitioned into the operating room after that. I did a cardiac operating room. It just made sense to me since cardiac was kind of my background. That was my comfort. And so I did CVOR. I actually moved out to Charleston, South Carolina, MUSC. By far, probably one of my favorite jobs I've had to this day. Totally fell in love with operating room nursing and everything CVOR related. And then I was working on my master's. And so I decided to move back to Illinois to be closer to some friends and family. And so that was when I took my current role at Springfield Memorial, where I'm at right now, just as a circulating nurse in the cardiac operating room. And then I transitioned up. I finished my master's, was offered a resource nurse position in the CVOR. So I did that for a little bit. And then I was eventually offered the manager role. And so I've been in that role for about 2 years now. So that's kind of what's led me to where I'm at right now.
Right. So what's the day-to-day like for a nurse who works in the CVOR?
I think every day is different, and I think that's one of the best parts about it. They come in for their shift, and they may be assigned to do 4 or 5 cases that take a couple hours for the day, or they may be in one long open heart for the day. And so, really, it offers a lot of variety, which I think is great. And then, one of the best parts of being in the OR too is you only have one patient at a time. You're never going to have more than that. So, the nurses really get to focus on their one patient, which I think is something you don't get to do a lot of times in nursing.
Yeah, I mean, besides trauma, I'm sure some of the cases are pretty long in the CVOR. What are some of the longer like cases that you've been in the CVOR?
Our open hearts are probably some of our longer cases, or open belly cases with vascular surgery, the open abdominal aortic aneurysms. Sometimes those cases can start when you come to work for your 8 or 10 hour shift, and then the call team may be relieving you at the end of your shift on the same case still. Um, Emergencies in the CVOR can take several hours sometimes. Those tend to be some of our longer cases. And then we also do some shorter lung cases, video assisted thoracoscopic procedures. So those are relatively quick. And then some smaller vascular procedures too, like fistulas.
Now, are you doing some of the like the hybrid type of stuff in the CVOR, like a TAVR?
We do help. Our CVOR team coordinates with our cath lab team at this hospital. And so they kind of tag team TAVRs together. It primarily is our cath lab team. However, I have seen that different at various places. I've seen where the CVOR team kind of owns that, and then sometimes cath lab owns it.
Okay. And what about some of the like the not the aneurysm cases where they go up and put the big like sheaths in? Like, is your team involved in that, or is that mostly cath lab as well?
It's mostly cath lab here at Springfield. We will provide a scrub tech sometimes if they have to do like a cut down in the groin. I've seen some CVORs. My previous one in South Carolina, our CVOR, we did those ourselves, and so our team, our nurses were cross trained to scrub and circulate, and they were able to do all those cases. There's some really fun cases though.
Yeah, yeah. I remember my first emergent case was a rupturing AAA, and it ruptured pretty quickly, and that turned pretty bloody and pretty gory.
I can imagine.
um, what about as an OR manager? What's the day-to-day like in that role?
I think the day to day varies a lot. I usually like to go in and kind of sit down in my office and check my emails from the afternoon previously and get caught up on that, see if there's anything pertinent that I need to go like relay to my team before the day kind of starts. Sometimes it's showing up to work and I've had texts and phone calls all morning, so I go straight back to the department, whether there's something that hasn't gone right, upset physician. So that kind of varies. And then usually meetings are kind of scattered throughout the day. I try to round on my team every morning, kind of check on the rooms, see if anybody needs anything. I help out with lunch breaks a lot, so that's typically my afternoon. And then after lunches, it's just kind of wrapping up anything that I know needs done before the end of the day, catching up on things. Having agency staff in the OR has created a lot of extra work, just getting in requests for those staff and making sure start dates are good, their requested time off, and my staffing is okay for the next day, and then kind of looking at it about a week ahead.
Now, how many rooms do you run on a typical day?
Our cardiac side, we just have the 4 operating rooms, so we try to run all 4 of those all day, every day.
Okay. I'm sure that can be a pretty busy day when Hazelrig has his long days.
Yes, he keeps us very busy.
What's the most rewarding part of being an OR nurse, and then as a nurse manager in the OR?
I think one of the most rewarding things being in the OR, taking care of the patients, is just you're helping them from such a different point of view than you are like when you're taking care of them on the floor, whether that's before or after surgery, if they ever need surgery. So it's seeing that from a different point of view, and then really like you are such a huge patient advocate while you're in the operating room because your patient is asleep. They can't be their voice. You are there to make sure the surgeon's doing what they're supposed to be doing, that everyone else in the room is doing their best to take care of the patient. And then speaking up if you see something wrong, which can be admittedly a little intimidating sometimes, especially if that's speaking up to the surgeon. And then I think being an OR manager, one of the most rewarding things that I've experienced so far is bringing in and hiring new graduates into the OR the last couple years. That was something we previously hadn't done at this hospital. And I think a lot of ORs really hadn't done that up until COVID. And then watching them like complete orientation and succeed. I've got one who has just excelled. She has learned to scrub after she learned the circulating role. She is my main charge nurse now. And so now she's looking back to go get her RNFA, her CNOR certification. So that just makes me happy. I've really enjoyed watching her journey and watching everyone else's journeys, completing orientation and really finding their way.
Have you had to transition a few more nurses to scrub than typical because of some of the shortages with techs?
We're trying. We did try to hire a new graduate nurse on to scrubbing before she learned the circulating role, and what we kind of found was she felt a little discouraged. She just felt like she wasn't really using what she had just learned in nursing school, and knowing how to do the scrub role, I completely get it. And so we've kind of focused on learning the circulating role first and then moving on to scrubbing. It does take time though, and then having all the agency staff, we are relying on them to train. That's difficult too.
Mhm.
And so it's kind of been a slow process for us. I've got 2 nurses that are cross-trained to do both roles, and then I hope to start working on a 3rd one within the next 6 months.
Yeah, it's just there's not very many schools that do scrub tech, so it's just so difficult to find somebody who's gone through a good program, and is able to come out and be ready to go, especially in the CVOR.
It's extremely difficult.
What's the most challenging part of your role?
I think one, just kind of having the agency staff and all the coordination and scheduling that takes, because we're not really getting them super far out. So when I started this role, I'd have my schedule out 2-3 months in advance. And now my schedule is coming out 2 weeks before, because I don't know if I'm going to have enough staff here. I don't know if I can run the 4 rooms these days. So that's been challenging and just time consuming. And I think one of the other difficult parts is just having some crucial conversations with staff. If they're not performing well, if there's issues with other team members, those conversations are never fun. And then staff obviously don't love having them either. So it's not something fun to do. I don't like doing it. It's hard for me. It's hard for them.
Yeah. What's the call schedule look like there? Is it like you're on for 5 and you're off for 5, that kind of thing? Or is it kind of all over the place?
It's kind of all over the place right now with the travelers. Typically fully staffed in an ideal world, they would be on once. It depends on the roles. The nurses are about every 8th weekend, 1 night a week. Some weeks they have a night off. The scrubs, it's a little more frequent just because there's not as many of them. And so that's always challenging, try to keep people in that role when there is a lot of call. I do try to I've been fortunate to get some travelers that really like taking extra call. So I've got some that'll take 2, 3, 4 nights of call a week. And that kind of helps me offload some call of my permanent staff while they're there. But we always seem to kind of have these lulls where the travelers are contracts are ending. And then I'm having my permanent staff take a couple nights of call a week, and they're like, I can't do this. And I'm like, just for a couple weeks, like we'll get through it.
Yeah, I think that was one of the things that was difficult for me in the OR, just because we were a very small team and there was only 2 of us that were trained for the cardiovascular side, and we were on call every other day and every other weekend.
Oh, that
So
is rough. That's definitely one of the downsides of being in the OR. And that's something we're actively working on to try to flex some general OR staff to get them trained on some of our procedures to cut down that call.
we've got a few students here with us today. I don't know if they have any questions they would like to ask, either about being a nurse manager in the OR or just working in the OR in general.
Hi, so my name is Stephanie. I'm a second year BSN student at UC Irvine in California. So I actually just wanted to say, first of all, so I'm actually a little bit interested in like OR nursing, but I've asked around and not many people are like, I have not met anybody that is an OR nurse. So I was actually really excited to be attending this meeting and to be hearing from you. So yeah, I do have one quick question. So from what I've heard, it's very hard to like get to be an OR nurse like straight out of undergrad. So like what I guess do you agree with that, or like what are your thoughts on that? Yeah.
Thanks for the question, Stephanie. I think 5-10 years ago, it was difficult for new graduates to be hired directly into the OR. I think that's changed a lot over the last few years, and I think it's becoming almost normal across the states to be hired into the operating room as a new graduate nurse. So I think it's definitely doable. I will say it's a long orientation. So if that is a route you decide to go, just remember that floor nursing, you've got a couple months of orientation and you're kind of off on your own. The OR can be anywhere from 6 months up to a year. It's a lot to learn. It's not a lot you see in nursing school. I'm sure you've probably kind of noticed that. And so it's just a totally different environment, but I think it's so fun and it can be a very rewarding career as long as you're willing to kind of stick out that orientation and realize there's so many things to learn, and you're not going to know everything in 2, 3, 4 months. Even once you're off of orientation and you start call by yourself, there's still going to be things you don't know, and you're going to be like, should I be doing this? Am I capable of doing this? And you absolutely are.
Thank you. And then I do have like another question as well. So I do know that like OR nursing, obviously looks very, very different, than like bedside nursing. So I was just wondering what, what are the things that like you do as a nurse, like in the operating room?
So I'll kind of just walk you through kind of a typical case. So your patients usually start off in like a preoperative area. And so you as the nurse will go talk to the patient, make sure their surgical consent is correct, it's accurate, it's signed and dated appropriately, asking some safety questions. We always ask, like, are your dentures out? Because if we're intubating you, we don't want to knock anything out of there. Asking if there's any metal in their body, and that's because a lot of times during surgery, you're using electrocautery devices, and then asking different if they've got any implants. We position differently in the OR, so sometimes that can be very important because you make sure you're not hurting the patient or giving them any pressure sores during surgery. And so once that's all kind of checked off, you'll take the patient back to the operating room, and then you'll usually move them over from their stretcher or bed onto an operating room table. And that's when you'll it's your responsibility to make sure the patient's positioned. You safety strap them to that bed to make sure they can't fall off. Just like you would as a floor nurse, you don't want your patient falling out of bed. A lot of our cases are supine in the CVOR. If you're in a different specialty, though, you might be doing some different positioning often. And so making sure bony prominences are padded appropriately. They're not going to have any issues after surgery with pressure sores, muscle damage, whatever. And then once they're kind of positioned and off to sleep, your job is really being that advocate for the patient, speaking up if you see something wrong, the surgeon's not doing what's on the consent, paying attention to the vitals. You always have your nurse anesthetist or anesthesiologist in the room who's really monitoring the patient and giving drugs. You'll give any drugs necessary that are needed on the field for like irrigation if you're washing something out. Getting any extra supplies and opening it to the sterile field during surgery. And then once surgery is over, you might help put dressings on the patient depending on the surgery, and then moving them back over, maybe extubating them, maybe they're staying intubated. It really depends on the surgery. Then moving them back over safely to their hospital bed, stretcher, and then helping transport them to PACU. That's kind of a broad overview of kind of like what your role as an OR nurse looks like.
Okay, thank you so much.
You're
Yeah,
welcome.
that was really interesting to hear, just because it's very different from what you think of when you think of nursing. So
It,
yeah,
it,
thank you
it
so
is
much.
very different, and you use your skills in a much different way than like what you're used to during clinicals and nursing school, I think.
Yeah. So did you ever have like how were you introduced to OR nursing?
Actually, we were able to get a couple days, brief days of OR clinicals in nursing school. It was just kind of shadowing. I was fortunate enough, I was waitressing during nursing school, and I actually had an OR charge nurse who was one of my customers, and she'd overheard me talking about being in nursing school one day and asked me if I wanted to come shadow. And so I got to go to Barnes Jewish in St. Louis, which is a really big hospital in our area, and I was able to shadow. I think I watched a craniotomy in the operating room and some other cases that day, and I got to spend a full day in the OR, and that was kind of what I don't even know what semester I was in, but that day I was like, this is what I want to do eventually. Like, it was so different. Feel like there's kind of an adrenaline rush with it, but it was just, I really enjoyed it.
Oh wow, that's really cool. Yeah, no, I don't think at my school, I don't think we get an OR rotation. But yeah, I think that's really cool that you got to experience that. And I do have another question. So I have been seeing that like recently, a lot of nurses have been leaving the field. So I guess my question is just like, what are your I guess like what are your thoughts on that? And then also like how do you feel like since you've entered the field and to where you are now, how do you feel like it's changed?
Oh, I do think it's changed. I think a lot of changes happened during COVID too. I think you're seeing a lot of nurses leaving the field. I don't know this for a fact, but I primarily see it being those floor nurses who are taking care of 7 or 8 patients a shift. And I can't imagine taking care of that many patients on a floor. When I worked on a cardiac step down, 5 or 6 patients was kind of maxed out for us. And that was kind of a lot for us at the time. There'd be nights I'd have 3 or 4 patients. So I can understand where that gets very overwhelming and exhausting shift after shift, which is one of the best things about the OR. You're never going to run into that issue because you only have the one patient at a time. I think I do see some people leave the OR for some work-life balance sometimes, depending on what your call requirement is. Some hospitals, I know, like Brandon said, he was on every other day for call, and unfortunately, no one really wants to do that in today's age. And so that is something I think a lot of hospitals and systems have recognized and are trying to do something to kind of fix that. And then I've seen call rotations in the OR be as few as like 3 to 4 times a month as well. So I think it really depends. Obviously, the less call typically tends to be more desirable for most people. So I have seen some people leave the OR when they've got small children at home. Maybe the call schedule doesn't fit with their child schedule, their spouse's schedule. It's typically something like that. I don't really see people leaving the OR as much as they do floor nursing because of the workload at work necessarily from day to day, just because it is so drastically different. And then I just think unfortunately, there's a bigger focus on finances and healthcare than there was 5 years ago too. And that's very hard. I think from a clinical nurse perspective, you always want to do what's best for your patient. And from a nurse manager, that's always your patient should always be first. But unfortunately, sometimes you do have to kind of look at things. If we can't afford to do this, we can't afford to keep our hospital doors open. And then what kind of care are we really able to provide to our community then? So I feel like sometimes there's sacrifices made that don't necessarily jeopardize patient care and are still considered safe, but maybe you think there's a little better option. And unfortunately, we're not always able to go with that better option anymore. And I think that's really hard to kind of understand and be okay with.
Thank you. Yeah, thank you. That was interesting to hear.
Yeah, it's different with each hospital too, because I see some of the critical access hospitals. They a lot of times they'll get people because they don't have call because they don't do emergent surgeries at some of the critical access hospitals. It's kind of those medium-sized hospitals that see probably the biggest problems, I would say, in the OR with like retaining staff because of the fact that it's smaller and you don't have as many staff members. So your rotation is a lot more frequent when it comes to call. Like when you start transitioning to some of the larger hospitals, like say a Barnes Jewish, you're going to have a lot of people, a lot of ORs, and the call works just differently in those places. I don't know, like if you agree with that, Hannah, like that's kind of what I've noticed.
I would definitely agree. I think your larger systems too, you typically have staff in-house 24/7, whereas like I have staff Monday through Friday until 5 p.m. and then I have a call team every single night and every single weekend. And even our main operating room, they staff 24/7. So they may have a call team, but they're getting called in to be the backup of the backup trauma team or something, which is so rare.
I don't have any more questions. Stephanie, you have anything else?
No, that was pretty much it, but it was really nice to hear from you.
And I hope if you choose to go down the operating room route, I hope you love it, and best of luck to you, Stephanie.
Thank you.
And thank you, Hannah, for taking the time out of your week to speak with us. It was great to get that perspective from the OR and learn a little bit about that particular area.
Thank you for having me, Brandon.
Thank you.